The Rare Kidney Source podcast is for informational and educational purposes only and should not be used as medical advice. Please speak with your healthcare provider before making any treatment decisions. Before we get started, don't forget to subscribe and hit the notification bell so you never miss an episode. Follow Rare Kidney Source on YouTube, Instagram, and Facebook, and listen or subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts.
When I was told that I had C3GN, my thoughts, of course, went to death. Outwardly, you look okay. It's just on paper that it says, oh, hey, you have this.
You can have an awful lot of inflammation or things going on within the kidney, and patients don't feel it.
I had a small child and I had two other small children. And so I decided that I needed to educate myself and really research and find out what this disease was.
Welcome back to the Rare Kidney Source.
Today, we are breaking down the basics of two rare kidney diseases, C3G and primary IC-MPGN, and the importance of receiving an early diagnosis.
And if you're newly diagnosed, supporting someone who is, or just trying to understand what all of these terms actually mean, you're in the right place.
Because one of the most surprising things about these diseases is that they can be active long before you ever feel something is wrong.
Most of us trust our bodies to alert us when something needs attention.
Pain, fatigue, a symptom that tells us, hey, something's up.
But these diseases don't always work that way.
Sometimes the first warning sign isn't how you feel.
It's what shows up in your labs.
And that's where today's story begins, with Lilly and nephrologist Joshua Thurman joining us today.
This episode of the Rare Kidney Source podcast is sponsored by Biogen, where courageous science and compassion drive our commitment to the rare kidney community. We believe people living with C3G and primary IC-MPGN deserve connection, understanding, and a community built around their needs. That's why we created Rare Kidney Source, a destination and podcast featuring real patient voices, leading experts, and trusted conversations to help you navigate your health journey with confidence. We're here to help you stay informed and connected. Visit rarekidneyandyou.com today.
My name is Lilly. I am a mom of 3 young boys, and I live in South Texas, and I am 43 years old.
My name is Joshua Thurman. I am a professor of nephrology at the University of Colorado. I've been here since 2000, so about 26 years. And I would say through my whole career, my research, my lab focus, and my clinical focus has been the complement system and kidney disease. This is an area that has been studied for a long time, but in the last few years has really been transformed. There are a lot of new insights and therapies in this area. So kind of an exciting time to be interested in what I'm interested in.
I have to agree with Dr. Thurman. It really is an exciting time to be interested in the complement system.
And Lilly, thank you for sharing a little bit about yourself as well. Like Lilly mentioned at the start of the episode, the worst case scenario is usually the first thing to come to mind.
As we heard from Lilly and from many people living with rare conditions, more often than not, the first challenge isn't navigating the disease itself.
Especially when what started as routine lab work suddenly becomes a conversation about a diagnosis you've never even heard of before.
And in Lily's case, that diagnosis arrived before she ever felt sick.
So in my story, I feel very fortunate. I went to my gynecologist actually was the one when I went for my follow-up appointment after I had my baby. He mentioned, "Hey, your proteins in your labs are kind of off. You might want to see a nephrologist." So I asked him, "Hey, can you refer me to a nephrologist?" So he did, and when I went to the nephrologist, he he felt also that, the labs were a little bit off. So he said, let me send you for a biopsy. And so I had my baby in July. I got my referral November, and then I got my biopsy done in December. And I don't know if this is uncommon, but when the radiologist came out, I remember him sitting on my bed and he handed me a paper and he told me, well, your biopsy shows you have C3GN.
Again, Lilly wasn't even feeling sick when she received her diagnosis.
She's not describing some major medical emergency. She was going about her everyday life, taking care of herself and her family.
What started as routine testing, just a regular follow-up appointment that had nothing to do with C3G, ended with a life-changing diagnosis.
And unfortunately, that isn't how it always happens. For many people living with a rare disease like C3G or primary IC-MPGN, getting to a diagnosis can take years.
So we asked Dr. Thurman about that reality and why getting answers isn't always as straightforward as it happened to be for Lilly.
Let me first comment on Lily's story because I completely agree with her. Her diagnosis sounds like it was so efficiently done and quickly done compared to many patients. And so I certainly am glad that the people who took care of you were so quick to notice the abnormalities and to really track them down because as you know, you can't make the diagnosis ultimately without a biopsy. And it kind of takes people to accrue a bunch of things that are worrying them to reach that point where they want to go ahead with the biopsy. But as your case shows, if people are paying attention, that can streamline the process and get you there sooner.
Once you have the diagnosis, the next question is almost unavoidable.
What is actually happening inside of my body?
I'm a complement person, so I always think of complement first and foremost. But these are diseases that I often say are really pure complement driven diseases. So the complement system is part of the immune system. It's this group of proteins that the body makes and it circulates in the body. And I would say these diseases, quite simply, are when that system loses control and starts activating and attacking the kidneys, which is why I say it's kind of a pure complement mediated disease in the sense that this immune system that should be bad for bacteria, bad for infections, but fine for yourself, suddenly gets turned on and hurts the kidneys and the glomerulus in particular.
Which raises an important question.
How is it that something so serious can be happening if you don't actually feel it?
The kidney is interesting in the sense that it has nerves on the outside of it. And so, of course, it's good if you don't feel pain from it. But what that means is that things can go on for a while before the patient becomes aware of it because the immune system is activated, the complement system is activated. And at the beginning, a patient would just have no way of feeling that or knowing it. When this starts to hurt the kidney, there is inflammation in the kidney, and the kidney, which is kind of like a filter for the blood, can start leaking things into the urine like blood. And sometimes that may become apparent. But actually, what patients first notice is often swelling of the feet after they have lost protein out of the blood. It goes out in the urine. And the way the body responds to that is by holding on to salt and water, and it ends up in the feet. So again, this can go on for a while before patients are aware of it, unless they just kind of happen to have had a blood or urine test. And then what they may notice is the swelling in the feet. They really don't notice anything in the kidney area of the back because, as I said, the kidney just doesn't really send the signal that the inflammation is going on.
That is a pretty remarkable reality because when we think about an illness, we often expect to feel something.
Pain, fatigue, some sort of a clear sign that something is just not right. But as Dr. Thurman explained, that isn't always how kidney disease works.
Let's think about it a different way. I want you to imagine a fortress under attack.
I always wanted my own fortress, but not the kind with sirens blaring or walls collapsing.
This fortress is more like the kind where tiny cracks begin forming inside the structure while everything on the outside looks completely normal.
And that's exactly what can make early diagnosis so important in diseases like C3G and primary IC-MPGN, because those first signs of trouble don't always present as symptoms.
In Lily's case, that's exactly what was happening. Her diagnosis began with abnormal labs, a look inside that then led to a biopsy and ultimately some answers.
And even after a diagnosis, those in-depth check-ins remain important because the condition of the fortress isn't measured by how it looks from the outside.
It's measured by what's happening within the walls.
So before we go any further, let's take a closer look at the kidneys themselves and the role they play in keeping those walls strong.
You can think of the kidneys as a filter, or really a million little filters, and the blood passes through these filters, and kind of the two things that you hope happens is that the waste products that the body generates go out in the urine, but the filter doesn't leak out things like blood and protein. So if you think of the kidneys as a filter, you want it to keep cleaning the blood, but not leak things out of the body that it should hold into the body. And when you get diseases of the kidney, both of those things can be disrupted. So sometimes the blood starts to accumulate things that the kidney should be clearing. And then the converse of that is sometimes the blood starts losing things that the kidney should be holding on to.
Every fortress depends on its gates, not because they're meant to keep everything out,
but because they're designed to let the right things pass through while keeping the wrong things from getting where they don't belong.
And in the kidneys, those gates are a lot like the filters Dr. Thurman just described. Every day, those filters are making thousands of decisions about what leaves the body and what stays protected.
And in Lilly's case, changes in those filtration symptoms showed up in routine testing, pointing doctors towards an initial diagnosis.
Let's do a little test, Kay. Waste trying to leave the fortress.
Open the gate.
Blood trying to leave.
Definitely not. Close the gate.
Protein?
Also staying inside our fortress. So in this case, the filtration gates are working properly. The decisions about what comes and goes happen quietly in the background.
But when the gates become damaged, things can start passing through that shouldn't.
And that is often what doctors tend to see first.
Long before someone starts to notice symptoms in themselves.
After hearing stories of other people and how long they had to wait to find out and how many doctors they had to see, I feel so fortunate that it was just a few steps that it took for me to get confirmation of what I had, right? And what was affecting my kidneys.
Lilly mentioned how after her doctor noticed the labs were irregular and referred her to a nephrologist, this ultimately led Lilly to having a kidney biopsy.
And while a biopsy can sound intimidating, it's also one of the most important tools doctors have when they're trying to understand exactly what's happening inside the kidneys.
Lab results can tell you if something's wrong, and a biopsy can reveal what's causing it.
Particularly in diseases like C3G and primary IC-MPGN, that often means taking a closer look at the kidney's filtration system.
The gates to our fortress.
Those filters are called glomeruli, and diseases that affect them are known as glomerular diseases.
So we asked Dr. Thurman to help us understand what all that really means.
Talking about glomerular diseases, within kidney diseases, we sometimes divide them into various types of diseases. And you could call some autoimmune diseases when the immune system of the body starts inappropriately attacking the kidney. And then glomerular diseases are diseases where the disease specifically affects those filters that I mentioned before, the place where blood is turned into urine. So as sort of a general rule, most forms of glomerulonephritis or glomerular disease are caused by something that turns on the immune system that inappropriately starts attacking your own body when really it should be very good at knowing friend from foe and not hurting the kidney.
So now we understand the fortress and the importance of the gates.
They are working hard to protect the precious valuables inside. So we understand what they're protecting, but we still haven't identified who or what is attacking them.
I'm picturing like a big battering ram carried by monsters.
I want so badly to agree with that, but sadly, I don't think that's it.
Because in C3G and primary IC-MPGN, the problem isn't an invading army. The kidneys are becoming a target of a system that normally helps defend the fortress.
To really understand why that happens, we need to talk about the complement system.
The complement system is, as I said before, it is part of the immune system, and it's an interesting group of proteins that circulate in the blood. And you could kind of think of it as this defense system that is always primed to detect an infection or a pathogen and to activate and destroy the pathogen. So if you have a system like that always active in your body, really the critical part of it is that it has to be able to know who should it attack or what cell should it attack and what cell should it not. And ordinarily, it does a very, very good job. We all walk around with the complement system in our blood going through our entire body, and it's all well controlled and things are good. However, with this system, if there is any imbalance for detecting what is friend and what is foe, it can be activated on your body's cells and lead to injury and even destruction of those cells in the same way that it should be doing that to bacteria. Now, an interesting thing for me scientifically is that when there's a problem with the complement system, the kidneys are commonly the target.
If the kidneys are the fortress and the thousands of tiny filters are the gates, that makes the complement system part of the security force.
The guards are assigned to identify threats and keep the fortress safe. Oh, like archers. They were always my favorite.
Yeah, let's think of them as part of the defending army just outside the gates, the first line of defense. Most days, they do their job exactly as intended.
Just like archers.
Yeah, they know the difference between friends and foes, and they take out the bad guys as they come.
See, they have so much in common with good archers.
But in C3G and primary IC-MPGN, that process of regulation can become distorted.
And when those archers lose track of who they're supposed to be protecting, even the best archers can miss the target sometimes.
Not just miss the target, they get so confused that they start firing at the gate.
Which is definitely not how fortress security is supposed to work. Bad archers.
You know so much about medieval times, Kay. So now the fortress is suffering damage from a system that was designed to protect it.
Sometimes the kidneys are the only target, even though complement is present everywhere in the body. And to answer why the kidneys are the specific target is really quite hard. And that's something that I've thought about a great deal and many people are researching. And I would say that there are probably unique characteristics of the kidney that just make it a little bit more vulnerable than other tissues in the body. But what happens is this balance of knowing friend versus foe gets tipped, and then the kidneys are suddenly no longer kind of in their protected state, and the system starts doing the same bad things on the kidney that it should be doing for bacteria or other infections.
One thing we appreciated about Dr. Thurman's explanation is that the complement system isn't the villain in this story. They're not just the archers for the kidney, they're the defense for the entire body.
The complement system is actually doing the job it's supposed to do, given the signs and clues it's being fed to identify the bad guys.
So, if something happens in the kidney that makes it present as a foe, of course the complement system is going to try and protect the rest of the body from that foe. The challenge here is that the balance between activation and regulation gets disrupted.
And that's exactly how the kidneys can end up caught in the middle.
I was able to connect with Dr. Nestor in Iowa, and I went and got the molecular testing done. We talked about the complements, and she explained this to me. And she told me, well, there could be three types, or there could be three reasons. This complement A, B, or unknown, right? Of why you have C3GN. And well, mine was the unknown. So I of course laughed because I thought, well, of course it would be the unknown, right? But like I said, I do feel very fortunate that my nephrologist has been very understanding in working with me when I have a question. He's very open to discussing, and I think he's also mentioned that I'm one of the only patients that he has that he sees that has C3GN. So I think he does also take an interest in knowing, right, like how the disease is going to progress, how it like manifests itself in the labs or in the treatment.
By this point, you can probably understand why getting answers isn't always straightforward.
The diagnosis itself may be rare, but the reasons behind it can be even more complex.
When complement is activated, it actually generates a bunch of different signals that trigger inflammation. And some of those act directly on the target. And actually, some of them go into the whole body and kind of engage the rest of the immune system. One of the things that complement does when it's activated is to take proteins from the blood and to attach them to the target surface. And actually, when we talk about a disease like C3G, or C3 glomerulopathy, it may sound like a weird name to people, but actually what that means is that when we do the biopsy, we are seeing the complement protein that has been attached to the kidney surface. It's kind of like this footprint of what has gone on, showing us that this system has been activated and is attacking the surface. We look at the C3, but what that's telling us is that these other things have been generated at the same time, some of which kind of form holes in the target surface, and some of which spread out through the body and bring in other immune cells and try to focus this broad immune attack on whatever the target is.
One thing I find absolutely fascinating is how much information a biopsy can actually reveal.
It's like getting a report from a contractor after they investigate the damage. We knew from the lab results that there likely was interior damage, but we needed a deeper look to find out what's happening inside the actual structure of our fortress walls.
So the contractor, or the doctor in this case, looks into the clues left behind by doing a biopsy to better understand what may be driving the disease.
Biopsies can also help doctors determine whether there's active disease, whether or not the disease is treatable, and if there's damage that's already become permanent.
Sounds like it's time to zoom in just a little bit more into what's actually happening inside the kidney and how that gets described medically versus how it can sometimes sound when you're hearing it for the first time.
Because in C3G and primary IC-MPGN, you'll often hear a couple of key terms come up when people are explaining what's going on.
Like scarring and inflammation.
He told me, right, that we had the filters and that this disease hardens those filters, which leads to like a sclerosis, right? Basically, like your kidneys getting hard. And so that makes the function go down. And so, he talked to me about like proteins, the creatinine, basically explained it like that. Yeah, that the kidneys get hard and so they filter less.
Your description, Lily, is very similar to what I often tell my patients, which is that in these autoimmune diseases or in these inflammatory diseases, we can kind of think of two things going on, very similar to what you just said. One is when the immune system gets activated, and that's kind of causing the problem. And then if that goes on too long, you get the scarring in the kidney.
Think about a fortress wall during a battle. Fresh damage can be assessed, but the attack is still happening, which makes fixing anything a challenge.
Stop the attack, and repairs may still be possible. But if enough time passes before the repairs begin, some of that damage becomes part of the wall itself. It becomes permanent.
That's the difference between inflammation and scarring.
The important point is that we can treat the first part, we can treat the inflammation. We have drugs that block it. But if things go on too long and you get the scarring, then there's really nothing that we can do anymore for it. And this is, of course, true for all disease, but the earlier we treat, the better. And really, when we do a kidney biopsy, one of the simple questions we have is there inflammation that we can treat? And if so, we should act right away. And then otherwise, is there scarring that we can't treat? And what is the balance of those?
The distinction between scarring and inflammation matters because it can help guide what comes next in care.
Not as a simple either or situation, but as part of understanding where a person is in the disease process.
Right. And this all connects to something we keep coming back to in C3G and primary IC-MPGN.
The earlier we can identify what's happening in the kidney, the more opportunity there is to intervene.
Early diagnosis truly matters.
But as we've heard, it's not so easy to get that diagnosis and sometimes not easy to know when you're in need of extra care and treatment.
So we asked Lilly how she specifically approached staying informed and keeping her fortress safe.
It's just the research. When I see my nephrologist, he'll share with me and say, information that he's received, from maybe people or conferences that he's gone to, people that come to visit him. He'll share that information with me. Of course, connecting with groups on Facebook also has been very helpful. I was surprised when I learned about this diagnosis that it commonly appears um, in young people. And so I was surprised, to have gotten it as a middle-aged person, woman, and so that was very interesting to me. And like I said, I felt fortunate that up to, it was my third child. And so I was done already. And so I feel fortunate for that. But, just I continue to research. I feel very fortunate to be part of this, to be able to have others to connect with. I know in June there's going to be a conference, a Neph Care conference, and so I'm hopefully planning to attend that to be able to meet other people that maybe possibly have what I have and just share stories because I do feel that like the saying says, strength in numbers, and not, realizing that you're not alone in what you're going through, because it is difficult to try to share with people that don't have your diagnosis, because it kind of, I feel like, goes over their head. They don't really understand what you're talking about.
Life with rare disease can be isolating, so connecting with others who understand what you're going through is really important.
And great advice. In Lily's case, that's exactly what happened.
What started as routine lab work became a series of questions that eventually gave her an answer. That process is what helped identify what was happening before she ever experienced many of the symptoms people often associate with kidney disease.
And that is why timing matters so much here. Because in C3G and primary IC-MPGN, symptoms alone don't always tell the full story.
Sometimes the earliest clues come from lab work, conversations with your healthcare team, and taking a closer look at what's happening inside your fortress, inside your kidney.
The big concern, and Lily mentioned this before as one of the first thoughts that came to her mind, but the big concern with any of these diseases is that if they proceed far enough, then you can end up with kidney failure. And once the kidney function is low enough, really our treatment options are hemodialysis or kidney transplant. And these are things that if one could do anything to avoid, that you should. I think that when there's still inflammation going on, we want to do everything possible to block and to suppress the inflammation so that if there's scarring and irreversible damage, we can prevent that before it progresses too far. So the earlier, the better with those things. And it's always a balance because we don't want to overreact if a patient is feeling well, of course. But if you know that there is an active inflammatory process in the kidney, the earlier that we can stop that, the less irreversible damage occurs. And we're hopefully keeping the patient as far as possible away from kidney failure, from dialysis, or the need for transplantation.
The fortress may look quiet from the outside,
But Lily and her care team are constantly checking the walls.
and that's why doctors spend so much time following trends.
Like watching lab work and monitoring changes, looking for signs that hopefully show that damage is not progressing.
Or catching signs that a new attack may be underway, like if inflammation may still be active.
The goal isn't just understanding what's happening today, it's protecting as much kidney function as possible for the future.
I do see my kidney doctor every 6 weeks. He's very proactive. And so every time we meet, he will go through my labs with me, and he'll show me the trends and say your creatinine was this much, but now because you've been taking your medicine a certain way, it's gone down to this. And so he'll show me the trend, right? Or he'll show me the proteins. They show me the trend on the proteins. And so we do have those discussions every time I go. And of course, for me personally, the one that's most important is the GFR. And so when I started, my GFR was 27, and right now it's at 50. And so I'm just, I'm really happy, right, with my treatment, and just with my doctor, and the fact that he does take time to talk to me, and he always makes sure, that I keep my appointments. Even the nurse will call me right away if I go for labs, and she'll say, "Hey, this was your readings. This is what came out." And I do feel fortunate that I have that kind of support from them, from the doctor's office, and that they've always kept track with me. There was a time that I wasn't feeling well with a medication that he gave me, and so I said, "Hey, can we try this instead?" Because I read about it, and so it ended up working really well. And so that's how we're going right now. And I know Dr. Thurman said sometimes the nephrologists feel the patients come in already, um, very educated on the situation. And so I do feel fortunate that my doctor is open to having those conversations and working with me to what I feel comfortable with.
And that kind of partnership and comfort with your care team is truly essential.
A lot of what guides care in these diseases comes from staying on top of labs and being aware of what's happening inside the kidneys, even when someone is feeling completely fine on the outside.
A core part of every discussion or every clinic visit with diseases like this, where on the one hand, medications do cause side effects, and if you're feeling well, you need to understand that your investing in the future, as it were. But then conversely, a lot of patients like Lilly have kind of read the worst case scenarios. And I think they kind of come in knowing if there is anything that can be done, they want to do it. And so I think that that's obviously a big part of the discussion about weighing the risks and benefits of treatment and knowing that sometimes you're doing it for the future, even though you feel well now.
And honestly, what came out of both of these conversations was a reminder that even in a space this complex,
And even for people who know it really, really well, there are still those moments where something clicks a little differently than before.
some of that came from surprising insights, some from comparing perspectives, but all of it adds something new to the way this story gets understood.
I think it's pretty interesting how he was sharing about the compliments and how the immune system just gets overactive, right? A lot of times we just think, oh, the immune system, if it's to help me, and it's surprising to know that, well, sometimes it can hurt you. And so I think it's good to know those things and just be aware, right? Because sometimes maybe we want to take something that's supposed to boost our immune system, but maybe in our case, it's not going to help, it's going to hurt. And so just being aware of those things and the research and still just taking time.
We as nephrologists, we talk to the patient and we look to the patient and we order an awful lot of blood tests and urine tests. This disease, unfortunately, right now, the only way to diagnose it is with a kidney biopsy, which is, of course, an invasive procedure where a needle is put into the kidney. And so, on the one hand, when we make the diagnosis, we know with pretty good confidence that this is the diagnosis, but you only get there after you have accumulated enough concern to go ahead with the biopsy. And so that, I think, still remains a big challenge for patients and for providers to know that no one wants to have to do a kidney biopsy, but really right now that is the only way to get this essential information.
Today's conversation started with a diagnosis, but along the way we learned that C3G and primary IC-MPGN are really stories about what happens when a system designed to protect us loses its balance.
We learned that the kidneys can be under attack long before someone feels sick, that a routine lab test can reveal something important,
And that sometimes the clues doctors need are hidden deep within the kidney itself.
What stood out to me most is that even after years of studying these diseases, there's still more to learn.
Absolutely. Lilly shared what it's like to live with rare kidney diseases, and Dr. Thurman helped us understand the science behind them.
Different perspectives, same disease. And when those perspectives come together, everyone walks away knowing a little more than they did before.
Including us. The Fortress may have made a few appearances today,
More than a few.
but whether you're thinking about filters, gates, archers, or lab results, the takeaway is the same.
Pay attention to the information available to you. Ask questions. Stay connected to your care team, because understanding what's happening inside the fortress can help protect it for the future.
And can lead to an early diagnosis and intervention, which is essentially the goal here.
Thank you to Dr. Thurman and Lilly for sharing their stories and expertise.
And thank you for listening to The Rare Kidney Source. To learn more, resources and tools for patients are available at rarekidneyandyou.com.
The Rare Kidney Source podcast is produced by Bloodstream Media and made possible by Biogen. If this conversation resonated with you, make sure you're subscribed and tap the notification bell so you don't miss what's coming next. Follow Rare Kidney Source on YouTube, Instagram, and Facebook, and listen or subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts. Thanks for being part of the community.